bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Sudhir Kale to start this session. Welcome, sir. Over to you.
Thanks, Navneet. Thanks, National Board. Welcome all here for today's quite an interesting session that is on MRI peritoneum in peritoneal surface malignancy and how to systematically interpret and assess PCI. So today's our main objectives will be on try to understand what is PSM and how does imaging help, how does radiology helps, especially focusing on MRI. So what are the key sequences when it comes to MRI peritoneum, and then coming to the imaging anatomy of the peritoneum. I will just go through the little bit of an anatomy of peritoneum for better understanding. Then PSM. So the peritoneal surface malignancy is basically a small definition about it and what does it comprise. Then we will systematically approach to assess the peritoneal spread, like how to assess the peritoneal spread on a cross-sectional imaging. Okay, so that is very, very vital for the surgeons and from the treatment perspective. And then we'll go to the radiological PCI, that is peritoneal carcinomatosis index. Then there is a mnemonic called as a bumpy assessment. So this is also we are going through it, and a few case-based reviews revealing the PCI. Okay. So now coming to introduction, imaging plays a vital role in the evaluation of patients with suspected or proven peritoneal malignancy. Despite significant advances in imaging technology, assessment of peritoneal pathology remains challenging. So, imaging of peritoneum, why it is challenging, right? So, mainly it is because of the complex peritoneal anatomy and then the extensive surface area of peritoneum that may host typically small nodular tumor deposits. So for us to image these small nodular deposits accurately and bring it in the report so that we can quantify the disease is always a challenge. So what do we have as imaging tools, radiology tools available currently? See, apart from the routine stuffs, we have quite an advanced imaging tools as of now with advanced technologies. Like, for instance, we have MDCT, multi-detector CT, has a good temporal as well as spatial resolution with the advanced slices like 128, 256 slices, widely used right now. Then we have a PET CT, as you all are aware, and then we have MRI. So today's topic, we will be discussing about MRI and its superiority over MDCT. So we'll just look into the next slide. Where does MRI really score over MDCTs? So MRI has superior soft tissue as well as contrast resolution. And because nowadays the MR have been advanced with many good sequences, so free breathing sequences, breath hold sequences, ECG and respiratory triggered sequences. I mean, now the current MR machines and equally good. We have the surface coil, torso coils. Initially, the torso coils were smaller. Now we have large torso coils which extend from above the level of diaphragm till the pelvis. And so these torso coils, and they are now digitized coils. Previously, they used to get analog signals on the coil. Now we have got directly digitization at the coil level. So the contrast, the image quality has quite superiorly improved. So, and adding to this, MR is superior to CT in characterizing bowel serosal implants. Then we have other tools like a very much improved high resolution diffusion weighted sequences Generally, these diffusion weighted sequences look for mitotic activity, the cellularity, restricted diffusion within the lesion. So this particular restricted diffusion is now enabled by various B factor images we put. So 0, 400, 800, 1200. Even the resolution has been maintained with higher B values, and so have a good quality diffusion. So this is very sensitive in picking up the smaller lesions right in the peritoneum. Then we have post contrast MRI. So then both have a better detection of not only sub-centimeter deposits, right, and also in the complex anatomical areas, like could be subdiaphragmatic difficult areas, especially in CT and all, we can very easily see in MPR because of its multiplanar capability. And the use of fat suppressed sequences and delayed post gadolinium enhanced sequences have allowed detection sensitivities to surpass that of CT. Okay, the presence of these advanced sequences. So it has been already proven that the peritoneal enhancement is better assessed by MRI than MDCT. So there is a definitive good evidence for us to objectively compare against the background liver parenchyma, whether the peritoneal enhancement is lesser than the liver parenchyma or equal to parenchyma or more than the liver parenchyma. This can be seen. We'll see in few of the slides. So this kind of enhancement, where unlike CT, it becomes difficult for us to visually delineate and tell that. So this makes MRI as the imaging modality of choice for peritoneal imaging, especially for detecting then kind of quantifying it, right? So let me just give a glance of what exactly MRI peritoneal imaging we do. That is, one is the much improved diffusion weighted imaging sequences, then the conventional but little high resolution T1 and T2 weighted fat suppression. So just for all benefit of everyone, who have been less exposed for MR or so. So generally T1 weighted is for pathology, and T1 weighted is for anatomy, and T2 weighted sequences are for pathology. And remember T2 as T2 signals. How do you identify with T2 signal? T2 signals basically is World War II. Water is white in T2. So anything, you have bladder, gallbladder, urinary bladder, and intestines with its fluid contents, or CSF and with its contents. Whenever these pockets are seen brighter, so then we know that it is a T2 weighted sequence. Okay, but now what happens is there is something called as fat in the body, which is distributed in subcutaneous areas, mesentery, everywhere, which can also remain brighter in T2 weighted images. So by doing a fat suppression, actually what we end up doing is we end up actually highlighting the areas with those with more water contents, like it could be edematous tumor tissues or normal the water containing tissues in the body, to be nicely seen. So this is what we mean by T2 fat suppressed sequences. Then we have contrast enhanced MRI. Just like we do for CT, we have gadolinium in MR, and gadolinium again we do similar kind of triple phase imaging, plus followed by for peritoneal imaging we follow a delayed 5 minutes scan. Okay, so that particular scan gives us a nice delineation of peritoneum. So in short, I would like to show these key sequences. What you need to know about is the diffusion. This is the diffusion weighted imaging. Okay, so you can see that generally the entire background, whichever is not highly cellular, not we do not show any restriction in diffusion, get completely suppressed in diffusion. And the structures which are showing, like the lesions here, the nodular lesions here in the anterior perihepatic space, so these gets highlighted. So similarly, you can see here in this particular section that you can see a deposit in the pouch of Douglas. You can see nicely seen, right? And plus a small nodule here. So all these areas get they light up in diffusion weighted images. And sometimes there may be a pseudo diffusion restrictions for which we use a processed images like apparent diffusion coefficient, which is ADC, and ADC is a counterpart of this diffusion. So basically all the restricted diffusion, all those which are significant, they tend to reverse. So ADC reversal, they become darker in ADC's images, right, in their counterpart images. So this is one point I want everyone to remember. Then the secondly, we have T2 weighted fat suppressed sequences. So as I told you, this ascitic fluid is it is bright or is it dark? It is bright. So bright means so water is white in T2. So it is a T2 weighted sequence. But what has happened to the subcutaneous fats? Is subcutaneous fat bright or dark? It is dark. So presence of this suggests that we have applied a fat suppression to this particular T2 weighted sequence. So what we end up getting is a T2 fat saturation, or sometimes you can hear people telling stir T2 IRFSE. So all these are the sequences, and these sequences are very, very important, right? So you can see there nice big little deposits in the left lumbar and left iliac fossa region and in the pouch of Douglas. So this is the second key sequence what you need to remember. Then third is this post contrast images. So you can see that the contrast is there in the aorta as well as in the veins, so the post contrast 5-minute sequence, what generally we see is you can see this nice like thin layer, and this is the liver, and there is so in T1 the fluid is darker. You can see this is the fluid around the liver, perihepatic fluid, and around the fluid we find a thin envelope, maybe thicker envelope covering, which you can see this. It is having subtle nodularity, and it is enhancing almost equal or more than the liver. So this particular sign, this particular the resolution, we can tell with diagnostic confidence that this is basically a diseased peritoneum, that is the peritoneal in peritoneal surface malignancies, right? And you can see it nicely here. There is one more nodular deposit here. So it is very easy for us to also measure the dimensions of these nodules in these particular areas, right? So this is about third, that is dynamic post contrast. So these three becomes the most important imaging sequences, but we always add a coronal plane of T2 IRFSE sequence to it to make it a complete protocol. Then coming to, so before we jump into the actual MR imaging interpretation, I would like to just kind of brush up on the imaging anatomy of peritoneum, because that will help us a little bit set ourselves up for understanding the PSM as well as PCI scores, right? So let's quickly go through the imaging anatomy of peritoneum. So before that, one or two slides on the schematic diagrams. So essentially we have visceral peritoneum that lines the intra-abdominal organs. So you can see the blue lines here. This particular represents the liver, large bowel, small bowel. So which lines these viscera are the visceral peritoneum, right? Then we have parietal peritoneum. Essentially the red lines here, you can see that along the anterior wall and along the posterior wall, and in the coronal plane it will be on the lateral aspects. So that forms the parietal peritoneum. Then we have specialized structures of peritoneum called mesentery. Basically, these are the double fold of peritoneum. You can see that this particular, it has a double fold here. double fold of visceral peritoneum, and encompasses what we call it as mesentery. And just another slide for this schematic showing the mesenteries generally are well connected to the posterior abdominal wall. Like you can see mesocolon here and small bowel mesentery here. But there are specialized mesenteries like greater omentum, which connects the stomach to the colon, and then lesser omentum, which connects stomach to the liver, and mesoappendix, which connect appendix to the cecum. So these are essentially not connected to the posterior abdominal wall. Now, we have seen this mesentery. Now, it's been always a challenge to see that in the cross-sectional images what you interpret. So for teaching purposes, for understanding the mesenteric anatomy, I am using few of the CT slides which are more apt for understanding the anatomy perspective. So the greater omentum is a double layer of peritoneum that attaches stomach to the another viscus. The greater omentum hangs from the greater curvature of stomach like an apron, and it attaches to the greater curvature of stomach to the anterior-superior aspect of transverse colon. Okay, so essentially in the sections, in a cross-sectional imaging, as you know, this is a subcutaneous fat, this is the rectus sheath here, and then just beneath that actually we find a properitoneal fat. Actually, when you zoom it high, you will be able to appreciate it. Then you have a thin layer of peritoneum. Thin layer of peritoneum can be seen very nicely, like a paper thin line can be seen. And then you have what you call as the omentum. So this is essentially, you will be seeing omentum in the form of omental fat, right? So in the form of this becomes the landmark. Okay, it is in front of the bowel loops, just along the posterior to the peritoneal line. Okay, and diseased omentum, what happens in diseased omentum, what you can see in the form of, it can be just a haziness of the omentum. There could be a nodularity, small nodules in the omentum. Sometimes we start having a large nodules. Then we have a confluent nodules. Then we have a mass-like formation in the omentum. These are variegated appearances of a pathological omentum. And you can see here very classically seen, like we describe this as a omental caking. And what are the various, in India, what are the various causes for omental caking most commonly seen? Malignancies, yes, and tuberculosis. Okay, so in malignancies, it could be lymphoma or the other malignancies, right? So these are the very most common causes. Then we have a lesser omentum. So how do we look into lesser omentum? So basically it's the gastrohepatic ligament which contains the left gastric artery and coronary vein, and hepatoduodenal ligament I will show, which hosts the hepatic artery, common hepatic duct, and portal vein. So you can see that, so this is the stomach. So we have a lesser sac, then epiploic foramina which opens into greater sac. Then we have these portal structures here. So this is the gastrohepatic ligament, and this is the hepatoduodenal ligament. And the same thing I will try to appreciate, and this is the gastrosplenic, splenorenal ligament, and falciform ligament. All these structures we will try to see in our cross-sectional images now. So this particular area, the left lobe of liver and the stomach. So the gastrohepatic interspace here, where the left gastric artery is there, right? So this particular area actually forms the gastrohepatic ligament. Okay, this is the area. So coming to the hepatoduodenal ligament. So the landmark for it is the presence of the portal vein, hepatic artery, and the duct. So all and cystic duct if possible. So this becomes the landmark for telling us that this is a region of hepatoduodenal ligament. Okay, so these are the landmarks. Please look into it whenever you are searching for these ligamental deposits. So coming to the gastrosplenic ligament. So it is delineated by the left gastroepiploic vessels. You can see here. So gastrosplenic ligament. Then we have spleno-renal ligament. So this again, the landmark here is the distal splenic artery. Distal splenic artery. So it this fat around it forms the spleno-renal ligament. Okay, spleen to kidney. Then the falciform ligament. So this is the remnant of most ventral part of the ventral mesentery, and it contains obliterated umbilical vein. Okay, this particular, right? So this forms the falciform ligament, generally very well seen when we're in the background of ascites. So with this, we'll just move on to few spaces. That is the lesser sac. It is a potential space between stomach and the pancreas. It is limited by the gastrosplenic and spleno-renal ligament, and it communicates with the greater sac on the right side through epiploic foramina. So this is what, how do we localize? So just above the level of pancreas, the posterior wall of stomach, you can see the fat here. So this particular area forms the lesser sac, and it joins the greater sac in the region of epiploic foramina. Okay, so this is how we need to localize it. Then coming to pelvic spaces, as you know, we have, this was a rectal malignancy, case of rectal malignancy, but I just want to show you the peritoneal reflection here. You can see this particular thin line here, okay, in between the uterus and the rectum. Okay, this particular line, so it's basically a peritoneal reflection, so recto-uterine pouch. Okay, whenever it gets filled up with fluid, it gets well delineated, and that is the most dependent part of the peritoneal cavity. Okay, so rectovesical in males, recto-uterine. So this particular, it has its very, very important, especially in PSM, because we start all our evaluation from here. So here actually the pouch of Douglas is very well appreciated. You can see the fluid actually filling up the uterus, and then you can have the amount of fluid filling up the pouch of Douglas, and the similar thing what is well delineated in a CT, corresponding CT images. Okay, I hope it is fine till now. So we just gone through this. Now the real session will begin about PSM and how do we systematically approach to assess the peritoneal spread. Okay, are you all ready for this? So yes, so let's begin. So peritoneal surface malignancy is the dissemination and implantation of tumor cells throughout the peritoneal cavity, often resulting in significant morbidity without systemic metastasis. So this, I hope the definition is quite clear. So it is the dissemination and implantation of tumor cells throughout the peritoneal cavity, okay, often resulting in significant. The peritoneal cavity is a common site for metastasis of most intraperitoneal malignancies. In general, peritoneal metastasis is a poor prognostic indicator. Okay, so it becomes that much essential for us to detect, diagnose, and then quantify it, right? Then, so PSM, peritoneal carcinomatosis or peritoneal surface malignancy, essentially can be primary or secondary metastatic. So primary is mainly mesotheliomas and primary peritoneal carcinomatosis, and secondary or metastatic ones are from GI, gynecological, and few other causes, right? So this is the entire structure in which the PSMs have been divided. Now coming to the MR image interpretation. So first is we have to establish whether this patient is having any peritoneal disease or not. So presence or absence of peritoneal metastasis. Okay, this becomes our first aim. And for this, we need to have certain protocols, certain mandatory sequences to be in place. Okay, so then in this, I would like everyone to emphasize that to have an axial T1 and T2 weighted IRFSC sequences. And generally we do a MOBI view here. MOBI is nothing but we do acquire sections of the upper abdomen and the pelvis, and these particular sections, for better viewing, they get stitched up. Actually, when it comes to a radiologist, he sees the entire volume of the sequence from the diaphragm till the pelvis, so that the flow doesn't get disturbed when you are trying to access. So many places there may be challenges because of the coils what they have, but many of the newer 1.5 Teslas and the 3 Teslas have this capability. Secondly, the other sequence is the coronal T2IR FSC sequence. So this brings an additional dimension, additional plane for the radiologist to always see. We do get some challenging areas, so where we need to confirm that particular lesion in the other plane. So coronal T2IR FSC sequence under the background of especially peritoneal diseases like fluid, this becomes a very, very useful sequence. Then the third one is the diffusion weighted sequences. So high resolution diffusion weighted image sequences. It's very important. So at least B800 to B1000. Okay. So based on the machines, I would suggest we should be acquiring this set of diffusion weighted sequences with a good excitation next with a number of excitations, so that the good SNR is there, and we can pick up very, very small nodules. Then coming to the next sequence is like any other contrast study, like it's a gadolinium enhanced MR images. Then we do a standard triple phase followed by 5 minutes post contrast scans for peritoneal imaging. So again, just to tell everyone that these are all mandatory sequences for a good peritoneal MR imaging. Okay, and now there was always a question, which Tesla is good, 3 Tesla or 1.5 Tesla. See, 3 Tesla is always superior because of its high capability, higher resolution, as well as it can reduce time because of the of its the overall good spatial resolution, right? And also it can have a good control over the respiratory triggered sequences, free breathing sequences. Okay, the time duration of the sequences can be shorter as compared to 1.5 Teslas. So because in bowel imaging, abdominal imaging challenges is the more these sequences more bigger than the bowel movement, lot of artifacts start creeping in. But having said that, 1.5 Teslas currently people they are coming up with good advanced softwares, so it is definitely possible in 1.5 Tesla too, but preference wise 3 Tesla is better. So now qualitative analysis of peritoneal metastasis. So what do we do? Like, see, now before quantifying it, we have to assess. So how do we really add value? So now is, once we know that there is a peritoneal metastasis, we can look into few of the places where the overall, for the surgeon, these are unresectable tumors, like the small bowel and mesentery. Okay, extensive involvement of these particular areas, serosal deposits. Then the presence of the deposits in the porta hepatis, hepatoduodenal ligament, or pelvic diffuse tumors. Okay, so it's very, very important as a part of the protocol to report all these areas clearly. Okay, then coming to detection of the lesions that require surgical subspecialty expertise, right? So so we can also add a note about these particular set of lesions. Then detection of occult peritoneal metastasis. Okay, so all these can be a part of our qualitative analysis of peritoneal metastasis. Okay, that's all about theory now. But now let's look practically, how do images are in front of you, like each one of you now. how do you start eyeballing it? How do you start interpreting? Because abdomen is a Pandora's box. I mean, it just opens up so many, like coronal image, I see now so many structures coming from diaphragm down to pelvis. So how to interpret? So these are few of the skills what you can use whenever you want to, you may look into peritoneum and the deposits, right? So in coronal plane, you follow what is called as a clockwise evaluation, right? What is clockwise evaluation? What do I mean? See, generally you can start it from the pelvis. So pelvis forms, it is around 6 o'clock position, right? And then we go all the way to the right iliac fossa, then right paracolic gutter, then go to the right perihepatic, subdiaphragmatic, then coming to epigastrium, then left perisplenic, left subdiaphragmatic, then left lumbar, left pelvis, and we come back to pelvis. Right? So this is what we use. Why do we use this? There is a reason for it. Because the peritoneal fluid flow, so it is said that the pelvic spaces, the fluid goes into the right paracolic gutter. From there goes to right subhepatic space, then right subphrenic space, then goes towards the left subphrenic or left perisplenic spaces, then left paracolic gutter and pelvic spaces. And then the supramesocolic and inframesocolic compartments through the lesser sac comes into the inframesocolic compartment. So inframesocolic compartment is divided by the root of mesentery into right and left. So you can have this peritoneal fluid coming back to right and left side of the abdomen, and then finally can go towards the pouch of Douglas. So this is the normal peritoneal fluid flow. Okay, so that's the reason why we also follow the similar protocol. For instance, here in this particular image, you can see that there are multiple nodular deposits here, and then when we just try to eyeball here and try to just follow the pink arrowheads here, so these are along the serosal surface of the ascending cecum and ascending colon. Then follow the yellow arrows. Yellow arrows essentially first goes into the omentum and then finally gets into the hepatorenal pouch and subhepatic space. Then follow these white arrows. It goes into the right paracolic gutter and then perihepatic space and then the subdiaphragmatic space here, right? Then similarly the fluid can track down into the epigastrium, subdiaphragmatic spaces, and then come to the left subdiaphragmatic space, left paracolic gutter into the pelvis. And this through the lesser sac in the inframesocolic compartment, it can come along the serosal deposits along the descending colon, or it can be the mesenteric nodular deposits here, right? So this is how we need to follow. And just I have a video clip. Let me just go through this video clip. Just you can have a quick look of the image sequences what we acquire. Okay, so now let me, yes, so generally when you hear, you can just keep eyeballing, come towards this pelvic area. Yes, you can stop it here. So you can see in the pelvis pouch of Douglas area, you can see that there are some deposits with the thickened peritoneum here, right? And then from here, I want everyone to just focus. Let's follow the clockwise rule here. Then we ascend towards the right iliac fossa. You can just see here. Then as I slowly go towards here, so you can see the cecum is little bit pulled up here, and you can see that there is an irregularity along the serosal aspect here, and you can see that fluid getting into the paracolic gutter, subhepatic spaces. There are few deposits here, and then as I slowly try to include the perihepatic space here, just focus on the perihepatic space here, and subdiaphragmatic, you can see a little bit of scalloping of the liver surface. You can see some nodularity, okay, nodularity and thickening. So then you come back to the epigastrium, epigastrium, then you go in for the left subdiaphragmatic space, then the left paracolic gutter, and left side of pelvis back to pelvis. And then also when you go back here, you can just go along the mesentery. You can see the deposits here, and the deposits along the root of mesentery and hepatoduodenal ligament area, right? So here, so all these areas are can be very easily and nicely interpreted if you go through systematically in a clockwise fashion in a coronal image. Now that is the clockwise, and always in radiology imaging, always you should always have another plane. That is, we have an axial plane, and it's always better you also try to one is whatever the findings you are seeing, you need to try to see it and also confirm it in the another plane. And moreover, for surgeons, this is the most bread and butter sequence, I think, because a lot of anatomy and the various details are which help them for their surgery is, and they're more used and trained to see these particular planes. So in this, what approach is followed is in an axial images, it is a double wagon wheel approach, right? So what do we mean by it? So basically it is an assessment of peritoneum from periphery to the center, from periphery to the center. Okay, so first is you go into greater omentum, then you see the bowel, then mesentery, then the root of mesentery. So you can see that, as I told you, the skin, subcutaneous fat, and these are the abdominal wall, and just behind that you find a layer, this particular green area. So this particular area forms the greater omentum. So that forms the first outer ring of the wagon wheel. Then we have the bowel loops here. So this forms the second. So you need to train your eyes looking in this way fashion, right? You sweep your eyes, first get into greater omentum, next sweep your eyes along the bowel, then sweep your eyes along the central mesentery and root of mesentery. So step by step from craniocaudally, when you are browsing, when you are looking into the images, slowly you have to go into these particular sections and confirm whether there are any deposits or not, right? So just to have, I have a video clip of axial images also. So this is what I actually mean by a Mobi view sequence. You can see that the sequences are just aligned in one particular, there is no split. You can just try to from the liver, spleen, aorta, stomach, kidneys, then mid-abdominal umbilical region, pelvis, and then coming down to lower pelvis till hip joints and pubic, inferior pubic, almost up to the level of ischial tuberosity. Okay, so entire thing I can just scroll without any hassles, without having to disconnect myself. Otherwise, many times it is done in two disconnected stacks. Okay, this is what I mean by Mobi view. Now coming to the wagon wheel approach in these particular cases, you can just, so this particular, you can see that. So you have abdominal subcutaneous fat, abdominal wall, and then this layer, basically you can see some nodular deposits here along this. So this is the omentum. So this second layer is the bowel. Third layer is the mesentery, and as you go higher up, the deepermost part is the root of mesentery, right? So this is how you need to approach when you are looking into systematically approach when you look into your axial images. PCI. So I think you are all aware of surgical PCI. So today we will just look into how do we quantify radiological PCI. So PCI refers to peritoneal carcinomatosis index, right? So I'm very thankful to Dr. Somshekhar sir, actually, like, because my journey towards PCI all started because the amount of cases he does and the quality of work, and this really helped me also to really focus on this particular field. And so I would definitely like to share my insights into this. And so peritoneal carcinomatosis index is a measure of a peritoneal disease spread that can be evaluated either surgically or radiologically. So PCI is a prognostic indicator and also helps in assessing the volume of tumor burden and likelihood of complete CRS, right? Cytoreductive surgeries. Then radiological PCI underestimates disease involvement, particularly small bowel. So still, involvement serosal deposits is challenging. Okay, so this is how it is made. See, the entire abdomen is divided into 9 quadrants here. So sagittal planes divides into 3 equal sectors, and axial planes at the costal margin and the anterior superior iliac spine divides this. And for all practical purpose, the labeling the central part, the umbilical region, this particular area is labeled as 0. Then we take a clockwise from the right hypochondrium. So 1, 2, 3, 4, 5, 6, 7, 8. Okay, so this is how. So mind you, it starts with 0, even though we have 9 quadrants. So we are starting with 0. So the final in the right lumbar region comes to 8. Apart from this, regions 9 to 12. So they divide this small bowel into 4 parts. That is, the jejunal loop, you divide it into upper jejunum and lower jejunum, and upper ileum and lower ileum. Okay, for looking into the serosal deposits, we divide this into. So this forms the sector 9, 10, 11 and 12. So totally we have 13, right? 13, not 12, because we are also including 0. Okay, so why I'm telling, so this in the next slide, I'll just try to explain. So we have 13 regions of peritoneal cavity for radiological PCI assessment. 0 corresponds to midline abdominal incision, entire greater omentum and transverse colon. Then the number 1 refers superior surface of right lobe of liver and under surface of right hemidiaphragm and right retrohepatic space. The sector 2 refers to epigastric fat pad in the left lobe of liver, lesser omentum and falciform ligament. Okay, so these are all come under sector 2. Coming to 3, under surface of left hem, just like on the right side, under surface of left hemidiaphragm, spleen, tail of pancreas, and anterior and posterior surfaces of stomach. And coming to 4, it is the descending colon and left abdominal gutter. Coming to 5, it is a pelvic side wall lateral to sigmoid colon. Then 6 is all the pelvic structures, female internal genitalia with ovaries, tubes, and uterus, bladder, pouch of Douglas, rectosigmoid colon forms the 6. 7, right pelvic wall. 8, right paracolic gutter. And 9, 10, as I told, it is jejunum, upper jejunum and lower jejunum. 11 and 12 forms upper ileum and lower ileum. So this is how these 13 regions or sectors of peritoneal cavities are assessed. And now coming to the scoring system. Scoring systems are based on the implant size, the metastasis or nodular size. So if it is less than 0.25 centimeters, very tiny dots, so then they are given a score of 1. And if the lesion size is in between 0.25 to 2.5 centimeters, they are given the score of 2. And if the size, and they are given a size of, score of 3 if it is more than 2.5 centimeters. Okay, 1, 2, and 3. So what is the maximum score can we expect here in 13 regions? It should be 39, right? 39. So prognostic significance, difference in 5 year survival, it is like PCIs of 10 and more, and PCIs of 10 and less. Okay, so there is a significant difference between these two regions. Quantification of the radiological peritoneal carcinomatosis index. Now, this is how we give in our report. Like, these are the various regions. So supposing if we have the greater omental deposits with a score of say 2, and the right lateral pelvic wall deposits of 3, more than 2.5 centimeters, and this is 0.25 to 2.5, then we add up 3 plus 2, so it is 5 out of 39, right? So now I'll just try to quickly look into what are the MR imaging appearances of the peritoneal diseases. Okay, then we are going to have few cases which I will try to show. So what are the MR imaging peritoneal diseases? What are the various types of diseases what you may encounter when you are seeing an MRI with a peritoneal disease? So these are one of the very commoner things where we can see either it could be a cystic or a solid lesions in the perihepatic space, and they are causing the scalloping of the liver surface. Okay, so you can see that this is a T2 weighted sequence, and this is a diffusion weighted sequence, very nicely lighting up. And this is a case of omental caking. You can see like a diffusely thickened omentum here. And this is in T2 fat sat images showing a diffuse omental caking, omental thickening. Okay, very nicely seen. So unlike in the previous case, maybe very difficult sometimes here to interpret, but it becomes much more easier for us to tell that all these things are basically pathological, not fat. Then coming to the deposits, so this is in the hepatoduodenal ligament area. So you can see the porta hepatis, the deposits are seen engulfing here. So very nicely demonstrated. And apart from this, you can see fluid here, some nodular deposits again seen in the anterior aspect. So these are all and then coming to the small bowel, the deposits along the small bowel mesentery. So these are the various kind of appearances what you will be seeing. Then these are all the pelvic deposits here, very ill-defined, irregular, and large. So pelvic deposits more than 2.5 centimeters. And there is an entity also called as the mesenteric implants. Mesenteric can induce what we call as an extensive fibrous desmoplastic reaction. They can be either mass-like or non-mass-like. Sometimes these can cause intestinal obstruction, adhesions. So it's very, very important for us to know these particular areas like mesenteric implants causing tethering and retraction of small bowel loops. All this can also be nicely seen. So this is the T2 weighted sequence, and this is the diffusion weighted sequence where you can see that irregular stellate appearance. And this is a mass-like appearance of the deposit. So these are the variegated appearances what you can come across. And these are just the video clips. I think I'm going to skip in the interest of time the similar which I have already scrolled initially to show how we look for the screening. And the corner sites for peritoneal metastasis, so gravity dependent areas, recto-uterine pouch, lateral paravesical spaces, right lower quadrant, right paracollicutor and sigmoid colon, and the places where there is arrested flow or aperistaltic like omentum, antropyloric area, ileus, cecal area or rectosigmoid junction. Or it could be areas of peritoneal fluid resorption like greater omentum and right subdiaphragmatic space. So assessment of critical areas, so this forms a very integral part of reporting. So it's very, very important from the radiology perspective to give these critical areas to the surgeons. So for this, there is a mnemonic called as BUMPY. So this is a very good article, Bumpy Road of Peritoneal Metastasis in Ovarian Cancer. Actually, this was shared by Dr. Somshekar sir. And so a very good article which shows how we actually look for bowel upper abdomen and mesentery in the peritoneal metastasis. Right, so we'll systematically try to look for all these areas, and especially in the patients with peritoneal. So we'll just go one by one. So small bowel involvement is a risk factor for suboptimal cytoreduction, nodules, segmental wall thickening, diffuse serosal infiltration, or a well-defined mass in the bowel. All these we need to really look for it, and we need to document it in our report. The site of bowel involvement, the amount of length of bowel involved, and the distance, and also not to forget the skip lesions. Okay, distance between the skip lesions and skip lesions all have to be reported. So as I told you, like you can see, there are skip lesions here. One is mass-like, one is having desmoplastic reaction, fibrous type, and causing tethering and involvement of small bowel loops. All these have to be documented in the report. So you can see the mesenteric, this particular mesenteric implant causing tethering and retraction of small bowel, and diffusion weighted imaging actually superimposed shows a DWI restriction on this. And also the bowel serosal deposits, you can see that they see nicely in the form of diffusion restricted areas along the serosal surface of the bowel. So coming to this particular rule, that resectable versus difficult to resect. So basically the mesenteric side. So mesenteric side, because of the mesenteric vasculature, presence of the deposits on this side is always difficult to resect, and so you can see that diffuse small bowel involvement in these areas. While on the non-mesenteric side, so scattered nodules always, these are all resectable conditions, mesenteric diseases, right? So coming to the next entity, that is U part of it, that is upper abdomen. So in the upper abdomen, it's very, very important for us to comment upon the involvement of gastrohepatic ligament, peripancreatic areas, then the hepatoduodenal ligaments like portocaval, periportal, and celiac axis, and the presence of retroperitoneal lymph nodes above the renal arteries. So these may be difficult to resect. Right, then coming to so this particular, you can see the deposits in the region of hepatoduodenal ligament, portal vein, large encasing this. Like all these are difficult resectable. And another entity, that is the presence of supradiaphragmatic nodes, which is very, very important because that is the only main route of lymphatic drainage from the peritoneal cavity to the chest. So all these also have to be noted down, and especially the lymph nodes more than 0.5 centimeters should raise a suspicion of stage 4 disease. And nowadays, I think even these supradiaphragmatic nodes are being approached through abdomen and they are resected, right? So a comment has also been made in these areas. Then coming to the mesentery part, central mesentery involvement is associated with poor outcome. Okay, so and presence of discrete nodules, infiltrations, and retraction of adjacent bowel loops. So, extensive central mesentery involvement also becomes one of the limiting factors. So, these are few of the references what I want everyone to have a look. Peritoneal MRI in patients undergoing cytoreductive surgery, then ovarian carcinomatosis MRI of peritoneum. Then I have few cases. I think if time permits, I can just quickly run through 3 or 4 cases just to show how we actually go in for PCI assessment. So 56-year-old female with a history of appendicular neoplasm post-surgery came for PCI evaluation. So you can see that, so this was a mucinous tumor, and you can see that perihepatic space and the falciform ligament, and then the hepatoduodenal ligament, then the involvement along the lesser omentum, and the presence of in the left side of the upper abdomen, So you can see left side of pelvis, right side of pelvis. I mean, these particular lesions very nicely seen. So multiple loculated fluid intensity collections in these areas, right? So in the paracolic gutters. So I have, let me just see if I can run these slides. Yes. So let's try to look into this particular case. So you can see that when we try to go systematically from below upwards, okay, you can find some deposits in the pouch of Douglas here, right? So then we go towards the right iliac fossa. You can see that just along the lateral pelvic wall, you can see that a small nodular deposit here. Then as we course further along the right paracolic gutter, you can see that the deposits going along the paracolic gutter, subhepatic space, and then involving the you can see that this involves the perihepatic space, then goes to subdiaphragmatic space on the top, and then coming back to falciform ligament, then epitoduodenal ligament, then we'll come to midline, then goes to left perisplenic area. I hope you're able to appreciate this icing kind of lesions on the spleen. Then when I come down here, you can see left paracolic gutter here. You can see there are nodular deposits here. And so as I come down left side of pelvis, and then back to pelvis, right? So so this is the same thing in the coronal. We need to follow the same clockwise rule here, right? In evaluating the for the PCI, for quantifying PCI. So basically this patient did not have the bowel loop involvement. So, and at most of the places, the nodules were more than 2.5 centimeters, so score of 3. So overall, this patient has PCI score of 24 on 39. So another 64-year-old female with a history of vague abdominal pain and vomiting. So this particular patient, you can see gross ascites, right? I just want everyone to focus. Okay. And let me just stop it here, and then I'll just try to take it back. So you can see there is a peritoneal thickening, little nodular deposits here. Then so this was actually mucinous adenocarcinoma, and you can just focus on this fluid filled stricture like a mucocele kind of appearance, and you can see that this is a ruptured mucocele, and the contents are going out here, and so, and also similar like we saw in the earlier case, the spread was quite extensive, and the lesions, you can see even the omentum, there are nodules here along the omentum, paracolic gutters, bilateral subdiaphragmatic, right? So you can see this nice mucocele on the right side. So this was a PCI of 24. I think we have reached 830 now. So just, 73-year-old primary malignancy, okay, high-grade serous ovarian, and so this was for assessing the treatment response. So this particular case had just 1 or 2 deposits here along the perihepatic space. This patient post-treatment shows PCI of 5. Then this was a case of recurrent granulosa cell tumor, and this patient had a PCI of 4, right? So so at the end, I would just like to conclude telling that as far as MRI peritoneum and is concerned, we should know what are the key sequences. And so essentially the MOBI-view T2-IR-FSC and T1 weighted sequence, coronal plane of T2-IR-FSC, followed by diffusion weighted, high resolution diffusion weighted imaging, and 5 minutes delayed contrast scans. So these are very most important key sequences. I want everyone to know anatomy. Of course, you all are already aware of it. And cross-sectional imaging anatomy, please go through it again and again. That helps. Then coming to peritoneal surface malignancies, how do we systematically approach to assess the peritoneal disease? The clockwise rule, double wagon wheel rule is very important. Then PCI, it's 13 sectors, and what is bumpy assessment, bowel, upper abdomen, and mesentery in peritoneal metastasis assessment. So all these I hope will add value, and it will add some value for you to take the imaging of peritoneum knowledge and apply it for your